Noting that we've got about 33 people that have joined us, so I think it's a suffice number for us to start our webinar. Let me start by greeting you all, and my name is Lwando Mdleleni. I'm from the Office of the DVC Research and Innovation. On behalf of Prof. France, I extend a warm welcome to you all, and thank you for joining us in this what we view as a very significant webinar. Perhaps a brief background to these webinars, particularly this webinar, and I just want to let you know that as an institution, we have committed to driving our strategic research objectives through the lenses of sustainable development. And one of the key approaches that we have adopted to advance this agenda is by fostering ongoing dialogues through webinar series. And today's discussion then revolves around the advancement of sustainable societies through research that underpins SDG3. Our aim really is to redefine the role that is played by higher education institutions in promoting sustainable communities and ensuring that universities make a more meaningful contribution, more impactful contribution to the sustainable development agenda. We are indeed then very fortunate to have esteemed speakers with us today who will share their remarkable work and their contributions to sustainable development. So we are hopeful that through their insights, we will be able to gain a deeper understanding of how research can support and how can we align it with SDG3. And our ultimate goal is to pave a way for other higher education institutions to actively engage in promoting sustainable practices and making positive impact on communities. We are hopeful or we envision a society where higher education institutions play a prominent role in shaping a sustainable future. So colleagues, I don't want to be long. Let's just make most of this opportunity to learn and collaborate for sustainable society. And once again, thank you for being part of this dialogue. Without further ado, you can see the program is listed is projected on the screen. Our moderator, who I'm going to introduce shortly, will then guide us through the program. And it is my pleasure to introduce today's moderator, Dr. Makaya Malema, who will guide us through this prolific and intriguing conversation. Dr. Malema is an early career researcher in the Developing the Scholar TTS program offered by the Office of the DVC Research and Innovation, and a senior lecturer in the Faculty of CHS in the Department of Sports, Recreation and Exercise. He holds a PhD in Sports, Recreation and Exercise with background in teaching and qualifications in sport, leisure and recreation management. His current research focuses on youth with disability leadership development, and leisure education. Makai is involved in community recreation programs with NGOs from disadvantaged backgrounds and health institutions for special populations. Makai is a committee member of the 2023 World Leisure International Innovation Prize Committee and a co-chair of the World Leisure Special Interest Group, SIG, Leisure for Youth and Children. He serves as a youth ambassador and a country coordinator of South Africa for the World Leisure Organization. He's also the country coordinator for the World Disability and Rehabilitation Conference in 2022-2023. Ladies and gentlemen, allow me to welcome Dr. Makaya Malema.
Thanks, Dr. Mdleleni, for the warm welcome. And thanks again to your office and the DVC in absentia for organizing these webinars for us to come and learn about how UWC contributes to the broader society. And I think today we are very fortunate to be listening to very wonderful speakers that will be sharing with us their contribution from the research side and their engagement with research and how they contribute towards the sustainable goal development. And quite fortunately is that now, I think 2023, we're marking almost the middle way through the introduction of the SDG goals. So it will be quite interesting to see how our speakers share their research, specifically with today's webinar aligned on SDG number 3. So without any further delays, I'm going to introduce the first speaker. I think Prof. Swart will be our first speaker. So just a brief introduction. Prof. Swart is from the Department of Dietetics and Nutrition here at UWC. She is the program leader within the DSI and NRF Center for Excellence in Food and Security. She is also a registered dietitian or a nutritionist with a PhD in public health. Her area of specialization is in public health nutrition, with focus on all prevention forms of malnutrition through nutrition policies and programs, as well as the evaluation of such policies and programs. So Prof. Swart will be speaking to us about sustainable nutrition, research challenges, and opportunities. Without any further delay, Prof. Swart, you can share your screen.
Thank you very much, Dr. Malema. I will quickly share. You should be able to see it. Please let me know if you can't. Thank you very much for this opportunity to share some information on sustainable nutrition. And I've chosen to speak a little bit about my research, but to position that within the challenges, and then hopefully also provide you with an opportunity to contribute to sustainable nutrition towards the end. Just please note that my research is funded by different organizations. And to start off with, I would like to define sustainable nutrition. It is the ability of the food system to provide sufficient energy and essential nutrients towards good health of the population without compromising the ability of future generations to meet their nutritional needs. So in brief, it is nutrition that is produced and delivered in a way that is mindful for people, the planet, and society. And it was quite difficult to decide what am I going to report on, because basically nutrition is linked to almost every single one of the sustainable development goals. But for today, I'm going to try and pose a couple of questions. What is known about climate change in the world? And then I'll give an example of some of the research that we've been doing. Then I will speak about what is known about the environmental impact as well as the health impact of food and diets. And I'll give an example. Specifically, the examples that I've chosen to speak about will focus on food consumption patterns and a brief mention of food waste, and then talk through what can we change to reduce our footprint. So to start with, we all know climate change is happening. There's regular reports of more flooding, more droughts, changes in temperature. And in the globe, Africa is most vulnerable. And it's recorded that the warming of Africa over the past decade has been higher than the global average. And similarly, the sea level rise along the African coastline is faster in Africa than what it is in the rest of the world. So a group of colleagues, we decided, it includes colleagues from Missouri University and then also Umeå University in Sweden. We decided to look at the prevalence of malnutrition in Africa, as reported by the latest DHS surveys in those countries, and then to explore any possible associations with 50-year temperature and precipitation changes. So what you see on the left-hand side of your screen is an indication of the prevalence of stunting, wasting, underweight, and overweight in young children at the last DHS survey in the countries that you can see highlighted. And the color chart that heat maps, the more red means that the public health significance of that particular condition is higher, whereas the green, it is low level of prevalence. On the right-hand side, you see a summary of the temperature changes, and we're talking about minimum temperature, mean temperature, as well as maximum temperature, and then the precipitation over the last 50 years prior to that particular DHS survey in those countries. And thanks to my colleagues in Sweden, who are very capable with data management, big data sets. And what did we find? So here you see basically that there was an association, and I'm not showing wasting and underweight, I'm just showing stunting, because that's the biggest problem in most of the countries. But we did find an association with the minimum temperature, mean temperature, as well as precipitation. But for overweight, obesity, children and adults, the picture was not so clear. This work is currently under review for publication. Okay, so what do we know about food and its contribution to global warming or the climate changes? So food production or food consumption in general contribute about 27% of the global emissions. And they are made up primarily by animal husbandry. So you have to add up, look at the red block, as well as crops for animal feed, the small green one, as well as the bigger brown one, which represents land use for livestock farming. And then also the green one, bigger green, dark green, will be for crops for human consumption. And at the top, the 3 blue bars represents kind of the supply chain, transportation of getting food products to the consumers, the packaging, and right on top, the food retail spaces where they sell food. So anything that we could do to change this kind of footprint will have an effect eventually on the climate. So just to sorry, I don't know what I did now. Now I have to go back through all of my slides. Okay, to go back. My apologies. I have to just get my slides to start again. I'm going to stop sharing and just fix my place in the slides, and then I'll join you again. And why is it not showing? There we're back. Thank you. So apologies for that. So just to give you a little bit more detail, if you were to be at the restaurant and you order a kilogram ribs, you've got a huge appetite for the day, then your contribution to greenhouse emissions will be about 99 kilograms, okay, of carbon dioxide. If you choose to eat a kilogram of bananas, so that would be the third one from the bottom, it would not even be 1 kilogram of carbon dioxide. So you can see that each food item we choose have got a very significant cost to the environment. We don't have these, haven't done the costing of the dietary intake in South Africa yet. We have a project that will be working towards that, but I think this also gives you already a sense of what is more environmentally costly and what would be your better choices. What is the cost of food or diets to health? Because everything that has got a health implication also impacts sustainability. Now, specifically, obesity and overweight is implicated. They are the primary causes for diabetes type 2, cardiovascular diseases, and at the moment, 40% of cancers are, diet is a causation factor in 40% of cancers, and soon will be overtaking tobacco as a cause. So it's definitely a significant problem. Obesity, and I'm going to focus on obesity, overweight. Yes, undernutrition has got similar negative implications, but you will see that on most of undernutrition, we have seen improvements, however, not in overweight and obesity, and that's why my focus is then on overweight and obesity. 80% of healthcare costs are related to these, to NCDs in general, including these three. Unfortunately, only 3% is spent on prevention of NCDs, and this is very preventable. So I said that we are in the process of doing a cost estimation for the country. We do not have nationally representative information on the dietary intake of South Africans. So in 2022, we led the National Dietary Intake Survey that collected data on dietary intake in South Africa. It's funded by the National Department of Health. And we will be rendering quite a lot of new information from that. And we hope that the results would be available before the end of the year. Some new data coming from this is then on adult dietary intake. That would be the first time that we have such a national survey for adults. We will also add adolescent dietary, school-going adolescent dietary intake, as well as the anthropometric status of adults and adolescents going to school. We've included mental health, alcohol intake, and oral health to all our participants, and that will also bring new data. And we will use this data also to then do a cost calculation of the environmental impact of the diet we consume in the country. But in the absence of that, we did a desktop review leading up to the National Dietary Intake Survey, and that was published last year, including 22 systematic reviews covering 22 years of national as well as small-scale local dietary intake surveys in the country. And I'm going to report quickly, very briefly, on some of the findings so that you can see what kind of nutritional problems we have, what kinds of foods we eat, and you can already, remembering the previous slides, think about what the implications would be for the country. I am going to rush through this very quickly because it's a lot of information, but let's get started with the nutritional status. So you can see, if you look at the numbers, that wasting, underweight has been decreasing slowly, with stunting remaining unchanged and overweight, obesity increasing slowly. If we, just to summarize this all in a picture, you'll see South Africa here compared to other countries at different levels of the obesity transition. The top red line, females in the country, the blue line, males, and the pink and light blue being children, girls and boys. And you see the trajectory for overweight and obesity is upwards. Preliminary data from our analysis so far, the situation is not necessarily improving. It seems to be deteriorating. So that's what we know about the nutritional status. However, that obesity and overweight is happening in the presence of continuing food insecurity, and currently the latest estimations is around about 17%, and you can see that between 2018 and 2022 it has increased, and that's due to COVID, job losses, and everything associated with that. So what do we eat in the country, and how does it impact positively or negatively? Dietary diversity is extremely low. You see that almost half of the population, this is adult population, do consume less than 4 different food groups out of 10 per day. For children, 50% of children in the country do not meet the minimum dietary diversity score. Why is that? Because of our food choices. So here you see the consumption of fruit and vegetables per person per day. And this is based on production levels in the country from the Food and Agricultural Organization balance sheets. The recommendation by the World Health Organization is 400 grams per person per day. We do not get to 50%. The types of fruit and vegetables chosen most commonly on the left-hand side, not always the most nutritious ones either, to support micronutrient or to prevent micronutrient malnutrition. Nuts and pulses, almost insignificant consumption levels based on production for nuts and pulses, but also based on sales data provided by Euromonitor, insignificant amounts. When we talk about dairy products, you'll see that we continue to consume more or less similar amounts of dairy products. However, there's a shift towards sweetened and flavored for all of the different beverages. I show you sugar-sweetened beverages at the bottom, the consumption levels, just as a comparison with choices that people make with regards to what they choose to consume. In terms of animal protein, consumption levels are adequate and slightly increasing. However, several of the foods not recommended by the food-based dietary guidelines have increased in consumption levels, and that's based on retail over the last 22 years, specifically between 2005 and 2019. And you can see, for example, plain biscuits increased by 250%. Potato chips increased by 130% for some crisps, for tortillas 50%. If you add up all of that, translates to around 28 grams per person per day. That's a small packet of crisps per person per day. And as I said, sugary beverages is close to a glass of sugary beverage per person per day. All of these products have got significant nutritional, but also environmental implications for the production of those products. We're in South Africa not alone. The graph you see here is the diet gap between the intake of different countries in 2016, and the black dotted line is the ideal. So you can see that overconsumption in the world on red meat, add to that eggs, poultry, and dairy products. In sub-Saharan Africa, we're specifically very high on starchy vegetables, very low on whole grains, and similarly, sub-Saharan Africa is the fourth bar from the top in each of these stacks. And you can see extreme low vegetable consumption in sub-Saharan Africa. Fruit, the lowest of all the regions. Whole grains, the lowest of all of the regions. And all of this contribute to our experience of overweight, obesity, and malnutrition. Another aspect that contributes to the environmental impact is food waste. And that is food waste right through the value chain that you see here. Of note, 10 million tons of food that is being produced. That's almost 50% of what we produce goes to waste every year. 18% of that comes from the household's contribution. So it goes to show that we could, by changing our practice, and this is South African numbers, this is not internationally, these are South African numbers from work done by the CSIR in 2020. We've worked on food, on waste pickers, landfill waste pickers, and you might know about that study that we have done. Half of them do collect food from the landfill waste sites for their daily consumption, even though several still prepare food at home, but there are a small portion that survive basically on the food that they collect from the dump sites. What are the implications of this for their own nutritional status? Of note, please note this light yellowish bar, which is the prevalence of overweight and obesity in females, compared to at that stage, the latest nutrition information we had, which came from the SADHS 2016, the darkest bar being the total females, and the light kind of orangey bar being the highest income quintile. So this is prevalent in highest income as well as in lowest income quintiles for men and for women. So what is if I can summarize the problem, is that we have a nutritional problem of growing overweight and obesity. It's over almost 70% if we combine the two at this stage. The causes of that, or contributing factors, not the only causes, but definitely contributing factors, would include overconsumption of foods excessive in sugar, saturated fat, and sodium. We consume insufficient amounts of fresh vegetables, fruit, legumes, nuts, and water. We consume excessive amounts of refined starches. We waste food excessively. And consumers have mentioned in surveys that access and cost of healthier foods are their main challenges. the cheaper versions that are excessive in sugar, saturated fat, and sodium are cheaper than the healthier versions. And unfortunately, these healthier versions that are energy dense, nutrient poor, are being marketed extremely aggressively. And that place a high premium in terms of desirability and aspirational value on these food products. So, in my opinion, what I think we could do as a country is to work towards strategies to ensure adequate healthy food production, healthy food availability at an affordable price, and also accessible to consumers where they are, all income consumers. I didn't include a slide on this, but we have done work on evaluating food environments, and you will find that in the poorer neighborhoods, you have excessive supplies, a much higher density of unhealthy food outlets, fast food outlets, and food outlets selling products high in excessive sugar, saturated fat, and sodium. And you will find sparse distribution of healthy food outlets, whereas in well-off neighborhoods, it is very much the opposite. We could and we should prevent the disproportionate advantage of unhealthy food that they get through the aggressive marketing. And this is not only because it's bad for nutrition, but also because of the products, as well as their containers, and the packaging and the marketing is not necessarily environmentally wise. Because of the food environments that makes choices so difficult for consumers to choose the healthy option, we do recommend that there should be some regulation to limit the production of products with nutrients of concern, or these high fat, high sugar and sodium products, and to regulate the marketing on them, and that there should be nudging efforts to nudge consumers towards healthier choices. So that's at the bigger scheme of things. But we have also researched some of those policies that we are recommending. We've researched some of them. Is the time up, Makaya?
1 minute to wrap up.
So I will skip through some of our research that we have done, just to say that we have evaluated policies, very poor implementation in South Africa, breastfeeding marketing, social media is being used to transgress regulations, sugary beverages showed a positive benefit. We've developed and evaluated potential warning labels that government is now implementing according to a nutrient profiling model. And I want to end with this. What strategies could we use and are needed on campus as opportunities to promote more sustainable development? I would suggest specifically that we work towards enabling environments for healthy food choices by trying to make healthy food more available and affordable, that we will prevent disproportionate advantage through marketing opportunities on campus, and that we should plan our food provisioning in such a way that we prevent waste, we recycle and we redistribute, and we choose packaging and sources that are environmentally wise. And we should prevent strategies that undermine sustainable food choices. I give 2 examples that appeared recently on campus. Nothing against the vending machine. The issue is that there are no healthy alternatives available in that vending machine. Systematic reviews found that exposure to these products in almost double consumption. And the same with brand loyalties. Brand loyalty development is indiscriminate about the healthiness or unhealthiness of the product. And therefore, we should be very careful when we allow marketing opportunities that could speak to these products. Thank you very much, and my apologies for not sticking to the time.
Thank you, Prof, for quite an informative talk. You know, honestly speaking, I feel sometimes the time is just too short, and I feel there's still more that we can learn from your talk. However, I think due to time, and apologies for having to rush and condense your presentation, but I'm sure to all the attendees, if you'd like, Prof, I think you can share some of the reading materials to our panels, or maybe you can share your email address and people can reach out if they have any more queries about what you presented. But I think also it's quite alarming, especially looking at the waste. And as you were speaking, Prof, I was just doing some introspection on my lunchbox as well. But yeah, quite informative. So without wasting any further time, I'm going to introduce the next speaker, Dr. Anam Nyembizi. So his training is in social psychology and with a passion on men's health research. And prior to joining UWC under the School of Public Health in January 2018 as a senior lecturer, he was a specialist in population health, health system and innovation at the Human Science Research Council, with research focusing on maternal and child health, sexual and reproductive health, mental health, and non-communicable diseases. His research interest continue to be on men's health, with a focus on social behavioral aspects of sexual reproductive health, HIV and AIDS, mental health, and non-communicable diseases, and as well as COVID-19. So his presentation today will be on a life course approach to promote health and well-being of boys and men. Without any further delay, Dr. Nyembezi, you can share your screen.
Thank you very much, Dr. Malema. I'm trying to share my screen. Oh, that's good. Okay, I hope you can see my screen.
Yes, sir.
Okay.
Whenever you're ready.
Okay. Thank you very much for the invitation to this great topic. I think I'll firstly like to indicate that this topic of men's health, it grew with me when I was doing my PhD, and I felt like there was a need for us to really look and investigate kind of behaviors that put men at risk. And at that time, I was more interested in sexual and sexual behaviors that put them at risk for HIV. But what I would like to share with you today is looking at the life course approach for boys and men. I just want to take out some of the things that are on top of my screen here. Sorry. Yeah. So there is a definition for a life course approach. It talks about it as being seen as a framework that is used in different parts of the world and has been advocated by the World Health Organization. And this framework, basically, it's been used to better understand the underlying biological, behavioral, and psychosocial processes that operates across the lifespan of a person in relation to future health. It really speaks about how we should understand that some of the determinants for health are linked to some of these issues of being a man, being a male, being a female, the age, and the likes. So it's got an aim that basically is about to ensure the well-being of people at all ages, and trying to address their needs and ensure that there is access available for health services. And also it speaks about some of the principles about health, which is the human rights, in order to ensure that at least there is a future for all human beings. And it's also part of the SDG3, because if you read SDG3, we see that it speaks about ensuring healthy lives and promoting well-being for all at all ages. So it's been integrated into the SDGs. And with regards to it, it's got some concepts, but what I would do, I would like to share with you the 3 concepts of life course, which is the first one talks about today's experiences and exposures influence tomorrow's health. And this is also part of why we think about when we have these kind of like frameworks, we think about projecting and having some goals to achieve in few years. And even the Western Cape government has got a Healthcare 2013, which also has some of its pillars. It's got the life course approach, and really it talks about having to understand that where we live as humans and where we learn, where we work, it is really about how it will influence our future. And the second concept, it talks about the pathways that are particular affected during a critical and sensitive period. So this approach, it basically speaks about the need for a particular interventions at a particular age or at a particular time frame, because there are certain life events that we need to look into at different stages, and we need to have interventions that are specifically targeted at that particular period. As we grow at different stages, and then there's a need for that. And then it talks about the importance of a community. And as we all know that the community that we live in, you know, it's we really need all of us to act and make sure that we promote good health. And the examples that I gave here is just about issues of gender-based violence. As we know that there is a need for men to be part and parcel of the solutions for gender-based violence. And that's why that part as men and communities, we need to be able to say, let's work together and make sure that we capacitate and have a healthy environment. And even in issues of schools, you know, learners need to be protected from gun violence, and as part of our environment, and we also need as a community to participate in that. And then we have the South African men's health strategy for 2020 to 2025, which is something that at least we can look forward to it and really think about what we can do to make sure that at least to implement some of its objectives, you know. And the 4 objectives that the strategy tries to is to empower and support men and boys to optimize their health and well-being. The strategy speaks about strengthening capacity to the health systems because as we know that some men they have low health seeking behaviors. So we need to find ways to say how we strengthen the community so that at least they can provide and understand the needs of men and boys. It also talks about making sure that we ensure that men they receive the treatment, care, and support that they need. And then the last objective, it speaks about making sure that we build evidence. We conduct research that will improve the lives of men and boys. So I think that's why it's very important for this seminar to speak about the importance of research, because we need to have evidence-based intervention. So this is what these objectives propose, or it seeks to achieve. And then as we understand that when we talk about men, there are certain healthy behaviors and risky behaviors. So for the health issues that this strategy speaks about, it speaks about these conditions that are faced by men, and some of the issues, some of the behaviors that contributes to those health issues. My area of interest is on health, on mental health currently, and you can see that how it contributes to the issues of alcohol, substance abuse, which starts at an early age for other adolescent boys, and issues of substance use, which is also prevalent among schools and learners as they are trying. I mean, it's a stage of adolescence where they're trying new things, and the issues of unsexual practices, the issues of non-condom use, the issues of multiple sexual partners, without even knowing their HIV status. So it's very important to understand that these are some of the things that contributes to their mental health. And the issue of diet, as Rena has spoken about, issues of diet, unhealthy diets that men find themselves in. But basically, these are some of the things that they basically talk about for all these health conditions. And then when it comes to the services that it really tries to say what we can do for boys and men, it talks about about 4 potential interventions that we can provide, or services that we can provide for boys and men. At prevention, it speaks about a whole list of things, and as we know that this kind of prevention, some of them, they vary from different stages of boys and men. And we know about the issues of gender-based violence, issues of violence among boys and men. We know about the issues of having this kind of prevention for HIV and AIDS, those to make sure that there's VMMC, there's PrEP, and all of that. And currently the issue of vaccination. And then the screening, it talks about, as men, I've mentioned that they have low health seeking behaviors. So it talks about the need for providing those services where men are being screened for all these kind of conditions. And we understand that some of these topics are linked to men at different stages. Like, for example, the issues of prostate cancer, they might be at a later age of their life course, whereas some of the issues might be even at an early age. And then the issues of treatment also based on the conditions and the retention. And this is what it basically proposed and says that we need to have these cross-cuttings where for interventions that deals with men, we have to increase the demand for services for men, and then provide supply the services, and then make sure that we have an enabling environment where we have laws, policies, and to make sure that men are involved and they participate. And then they've grouped the target groups into adolescents, young men, and older men. And those packages are relevant for those, but some of them they cut across because issues of unprotected sexual practices, you find that issues of HIV go across different stages from adolescents to older men. And then these are some of the projects that I want to share with you. I'm currently involved in 3 projects at the School of Public Health since I joined. And this is one of the projects that we are funded by IDRC. It looks at the gender transformation for Africa, a sexual and reproductive and maternal health research collaboration. Basically, what we're trying to do is to say some of the programs that have been implemented in terms of sexual and reproductive health are not gender transformative. And basically what we try to say is that there is a need for them in the continuum of gender transformation to make sure that they respond to the needs of the community. And there is an involvement of boys and men. And that's why we have seen in the past few years that there are programs where they engage boys and men because the health of a boy and a man is very important, but it's not only important for them, it's also important for maternal health because they are the fathers, they are the fathers of the babies, they are the parents of the girl child. So it's very important to make sure that we have this gender transformation approach. And one of the examples that we currently working on, we're working with Stronger Justice, and there's a program that they're implementing with this One Youth Can. And what we do, we're trying to look at it whether we can, as much as its own aim is to change norms, gender norms, and promote gender equality. We also want to see whether there's an opportunity for it to be gender transformative and make sure that the issues of men, engaging men and engaging boys is very important to make sure that there's a success. And then another project that I'm involved in, it talks about there's a WHO project that we currently involved with other colleagues from Queen's, Stellenbosch, and it looked at the research priority setting exercise for the sexual and reproductive health and rights of men. So we basically trying to contribute to set the agenda, what research needs to be done. And then we involved different stakeholders, and we had 2 kind of like approaches where there was a focus group discussions in different countries of the world, but we categorized them based on Anglophones and some with Francophones and Africa, and we did try to make sure that at least we give voice to each continent. And then we asked them to give us kind of like what will be their research priorities. And then what you see here is just I'm sharing with you some preliminary findings from our research. So we had 4 thematic domains for that after we did the research prioritization. So the first domain was to understand masculinity and gender equality. And then the other one was to make sure that at least we contribute in terms of how we can improve the programs to advance gender equality by addressing the issues of masculinity. And domain 3, we've looked into the improving the equitable and right-based services and policies. And then the last one was to improve the way we conduct research on this topic of masculinity and sexual and reproductive health and rights. We then, after have done some analysis, we found that There were about 25 research priorities that came out, and then we categorized them into, these are the top 10, these are the lower 10, and and then these are the middle topics that came out, and the colors are linked to the domains. And as you can see, that the majority of the people felt like there's a need for us to understand the diverse sexual and reproductive health needs. We need to really look into the gender norms. We need to engage men and boys, you know, so these were kind of things that they really were interested to say. The research on men should look into these issues. So it's just to show you some of the preliminary results, basically. And then the last project that I want to share with you, colleagues, is the project that I'm involved in as a PI, as a principal investigator, and we are doing it in the Eastern Cape. So we're looking, I'm looking at the mental health among males who have been traditionally circumcised. So how it started, it's basically what we've been reading on the news, what we've been listening on the radio, TV, where we find that there are a number of deaths and injuries that are related to traditional circumcision in the Eastern Cape and across the country. And so what I'm interested in is to, as I understand that this is a rite of passage from boyhood to manhood, and then it really resonates with the framework of life course approach. And what I'm interested in is to understand the mental health of boys, if I were to put it, in two ways, as they prepare themselves for this initiation as a rite of passage at an early age. What kind of what are their anxieties, what kind of things that they think about that can go wrong with this, you know, and how does it affect them? And also as boys, those that know more about this, boys do participate during this process, and they have a role that they play during this phase, during the seasons. An example would be to bring the food from home to the place where these initiates stay. So, I mean, you can imagine in instances where they've experienced death or injuries among those that they were taking care of. That's some of the things that they might have as post-traumatic stress, and you can name them, and all of those things. And also, as I'm saying, during the initiation and circumcision, if there is any problem, then you get hospitalized or you visit the hospital. You are not regarded as a man at all, so you don't attain the status of being a man. And some of those things, there's a stigma around it. And what are kind of like some of the things that these men are thinking as an adolescent man, as an adolescent boy? What is it that they think about it? What is the future? How are they going to be accepted in the communities? So we're currently conducting surveys in the hospitals at the OR Tambo, and trying to understand some of the things that they're thinking, because they will be stigmatized, you know, and all of that. And in terms of the men, also at young men above 35, some of them, they do take care of them. They are called traditional nurses, for the lack of a better translation word for my audience. So they do take care of these boys. And if something else happens, I mean, what is their also mental health status? What are they thinking? But also the community at all, because we really have to think about the health of these guys. So what I'm trying to also link this to is if you look at this framework that I've shared, is to say sometimes you find that some of the things that are the risk factors to these injuries and deaths are related to those factors that I mentioned about substance use, alcohol, issues of violence. Some are assaulted, some, there's a lot of things that are happening to them that are unfortunate, and some of them are not even related to the practice that they are undergoing. So we really are trying to say in this presentation that in conclusion that the life course approach is kind of like a research that is needed that can probably work if there is a partnership in terms of delivering services, even to the communities and at home, even as my area of interest in this topic is more kind of like in rural health. So some of those things, and then there's also a possibility that there's a need for a multi-sectoral action in order to deal with some of these determinants, as I've mentioned, that issues of violence. Some of these issues, they really need sectors such as traditional leaders who can who are working in the communities, who can also contribute in terms of dealing with some of these issues. And also speaking about this topic, I'm thinking about the Geneva Charter for Well-being, which is also about creating sustainable well-being for the societies. So there's a need for us to commit ourselves in terms of conducting this kind of research in order for us to make sure that at least there is equitable health for now and for future generations. Because indeed this framework it's about dealing with issues of inequity, in health and the likes. With that, colleagues, I'll end my presentation. Thank you so much.
Thanks, Dr. Now. Quite a mouthful, honestly, and yet very informative presentation. And I know, given the platform, you can speak to us for hours on this passionate niche of yours, and we really do appreciate you condensing it into this little short time. And we hope we can get more opportunities for you to share more insights about the topic. But thank you so much. And I'm seeing Q&As in the chats. For anyone that has a burning question, you can just post it in the chats, or later on we'll maybe take 1 or 2 questions from the audience. But if not, after each speaker, you can just post your questions, and then our panelists will try and answer your question. If needs be, then via email, they can try to respond to your questions and queries, and then we'll take it from there. So now we're gonna introduce our third speaker, which is Professor Jennifer Chips. Prof. Chips is currently a chairperson in Person-Centered Digital Health, after previously serving as a director for the School of Nursing and the division head responsible for research and internationalization in the School of Nursing. But before she joined UWC, she was in the University of Sydney in Australia, the NZHRC in New Zealand, and the NSW Department of Health and at UKZN in South Africa. She holds a PhD in telemedicine from the University of KwaZulu-Natal, and her research interests include digital health, in artificial intelligence, digital health, evaluations, mental health intervention programs, educational digital technologies, and systematic reviews. She'll be speaking to us today about the advancement of sustainable society through research that underpins SDG goal number 3. Professor Chips, you can share your screen.
Okay, is that clear?
Yes,
Thank
Prof.
you very much. I'll try and I speak very fast, and I do apologize for people that have heard me say some of these things before. As people know, I'm the chair in digital health, and this area is such a big area. I try to provide an overview today of some of the issues as it relates to SDGs, but also highlighting some of the research, not only my research, but research here at UWC. So the WHO has been arguing that digital health is essential for universal health coverage. And this universal health coverage is a prime focus for global health SDGs. And so that's primarily, I think, that I'm going to focus on is the way that digital health can provide access to universal health coverage. As everybody is aware, and life is just changing rapidly as we are speaking. And, you know, I just read a quote, and I was saying it in another webinar the other day, that, you know, artificial intelligence has become the new electricity. You know, there's been such an exponential increase in the use of digital technologies in life in general, in computers, smartphones, artificial intelligence, robotics, virtual reality. People know that our university has just opened a digital innovation center. You know, so it has been a tremendous growth in technology, and our world is changing. But the impact of COVID, and also this global aim from the WHO around accessing equitable healthcare through the Sustainable Development Goals, have really brought digital health to the front. In South Africa and internationally, there's been a lot of support with it, with strategies. There's a global strategy on digital health from the WHO. And in South Africa, we also have the vision for South Africa as better health for all South Africans, enabled by person-centered digital health. So digital health has become central to most of health thinking and planning. So we've got to start off again, and I apologize for repeating some of the things that people might have heard before, but it is growing and changing as we speak. Technology, digital health is around technologies that are used in health. And I think it's very important to remember that the digital technologies are just a vehicle for the delivery of health services. The aim of these technologies is to improve health and to contribute towards this equitable access to healthcare, but it is a platform to host services and health interventions that service clinicians, clients, and health system. And this is the area that has just expanded, because it used to be telemedicine, and then it became telehealth, and then it became e-health, and now it all includes m-health as well. It includes information communication technologies, electronic medical records, which have been around for quite a while. The world of artificial intelligence has just been expanding rapidly. There's been a lot of work previously in predictive AI, but now the work with ChatGPT, etc., has also now increased this generative AI impact on health. Data analytics, virtual reality, augmented reality, wearable devices, home monitoring, the Internet of Things, robotics, and you know, and I can't even continue to mention all the rest that's there. So it's a very, very, very broad area. But these digital technologies are seen as key enablers of the 17 Sustainable Development Goals. It's central to universal access to healthcare in SDG3. It has the potential through this to reduce inequalities in SDG 10, and therefore can contribute to addressing poverty in SDG 1. There's also, with SDG 9, a focus on the investments in ICT and research in public and private sectors. It can foster development of cross-sectoral collaboration between health, IT, public and private, and it can contribute to health worker education. So it's become very central to all of the Sustainable Development Goals. But specifically to SDG 3, and I just pulled out a few things here as examples. Obviously, the main thing is this access to delivery of quality healthcare. So universal access to healthcare, and this is, you know, the prime areas for this has been telehealth and virtual healthcare. And this is sort of an interesting area because with COVID, the whole program around telehealth and virtual healthcare has just changed. There's also the areas around improved knowledge and access to health information, which is goal 3.4. And here big issues around health literacy, especially for the non-communicable diseases through the use of mobile devices and apps. There's the possibility for care coordination in the management and treatment of diseases, again through the electronic medical health records and digital decision-making tools. Digital surveillance to improve early warning systems relating to Target 3D, access and integration and support for health professional training, which is 3.4 and 4, And this is through online courses, chatbots, artificial, augmented and virtual reality, and also through surveillance, access to safe, effective quality essential medicines through indicator-based surveillance. So there's numerous areas in which digital health has become a key enabler as the world has changed. But there's some principles that we have to consider when we talk about digital health, because the use of digital health technology should be based on need. So it should not be because this is a nice, shiny little new app that everybody likes to use, but that it should actually be addressing a health need out there, for example, to provide access to scarce health services. Because of the field being digital health, it is really a field that involves multiple disciplines. And so it should be, and any development in this field should be co-designed, and it should be based on user-centered principles with users and stakeholders with expertise in health, technology, psychology for behavior change, because a lot of the activities are around behavior change, bioinformatics, ICT, research. So very, very strong transdisciplinary focus, more so than, even beyond multidisciplinary to transdisciplinary, creating new focus area and work. But we as a faculty, as everybody knows, very much focus on social justice. So digital health should also be located into this ethical social justice framework, where technical innovations are contextualized as social innovations, improving the lives of people. Then a big new area that has been developing and growing has been around the principles of actually evaluation of this digital health technology, because there's been such an uptake of the technology that there hasn't been a formal process, and something like the health technology assessment framework, which has been routinely used and implemented for other health technology, has not yet been applied to digital health. Then the issue of implementation science is very key, and one of the key problems, I think, is sustainability. And as I talk a little bit about some of the research that we've done, you can see that the ongoing uptake and scalability of the research has got major challenges, and infrastructure and affordability issues. And then there's the issue of what research are we doing in digital health, which I want to just kind of briefly touch on. So if I was to start with mHealth, mHealth is the use of mobile phones. Now, this obviously has become very popular. We all use WhatsApp. We lived with WhatsApp during the pandemic. But, within this field of mHealth, there's been a proliferation of apps. You can get apps for everything under the sun. For example, the Visa app, which is an anxiety in therapy chatbot, which has been recommended for the use of stress and anxiety. In our faculty as well, we are currently doing some work, and I was listening to the previous presenter, and I thought it was important probably for the two of them to link up, because Professor Trulita Crowley from the School of Nursing has developed an app. It's called the Smart App, and you can see a little picture there for self-management for adolescents with HIV, for them to be resilient and thrive. And so that was a PhD work, which is now continued post as well. Also in our university, I'm aware of this, although I haven't seen it, is that our university has been working hard to prevent the deaf community from being isolated. So again, focusing on access through the Science Support app, where this app communicates instructions with a drop-down text menu and with sign language, and it includes photos and medication reminders, and it was designed to mimic the way pharmacists typically counsel people, which I think is a very exciting development. Some of our own research is looking at mHealth in low and middle income countries for the delivery of treatment. My background is mental health. So my PhD student actually developed an intervention, a low intensity cognitive behavioral therapy intervention for lonely older adults. And so we decided on the use of WhatsApp as the delivery vehicle for it. But we did a systematic review, and what was identified in the systematic review that there were two interventions that were effective for the management of loneliness in older people, which was cognitive restructuring and psychoeducation. So we then developed this therapy program, which is a low intensity cognitive behavioral therapy program that could be delivered by non-psychologists. And we got everybody, all the older people in this residential area on WhatsApp, and developed some psychoeducation, sending reinforcing messages on WhatsApp, and then did some individualized, positively worded message addressing maladaptive cognitions via WhatsApp. The project was really very successful in its evaluation. There was increased WhatsApp usage, and I always tell people that the most amazing thing for me is one of the older gentlemen actually is now the technical officer in the place where they live for WhatsApp, and he attended my students' graduation. But what the study did show with the trial we did, that it decreased cognitions of disconnection and rejection, and a decreased loneliness level, and this was also sustained. So it showed that you could actually use something like WhatsApp as a vehicle to deliver some low intensity CBT. Similarly, there's a number of projects done in Africa by some of my students around self-care management, and that's a very common area that is being used for. One of my students did a mobile intervention for diabetes self-management for people living with diabetes in Ghana. So she looked at both voice and text messages and found a preference for a combination of the two. My student, Dr. Dzanzi, looked at mobile interventions for adherence to antiretroviral treatment for HIV infections. And Dr. Shola looked at mobile phones for delivering of acceptance and commitment therapy in the prevention of mother-to-child transmission of HIV in Nigeria. Now, one of the challenges with this is that I would just briefly mention is that, in fact, these programs are quite resource intensive and have not been able to be sustained and integrated. We've also done it for education, and this is just an example of a program that we did also on WhatsApp to empower new graduate nurses. Then there's, of course, this whole new area of artificial intelligence in healthcare, which has just been taken off. So one of the key areas is just access to information. We've got funding for a little project called Nurse Care, which is looking at a chatbot, which is to be developed to support nurses. It's very new. We just received funding. Then outside of the field, there's a lot of emotional assistance robots. There's smart homes, which monitor, for example, older people, whether their movement and their mobility. And these are just pictures of some of the robots that are out there for use. Then the area of generative AI is just taken up, and for most people, this is the ChatGPT area, the big language model transformation. So this has also been taken up into health, in transcribing patient records, for example. And so one of the things people are saying that beyond saving us time, the intelligence in AI, if used well, could make us better at our jobs because it could free up some time. And then it has already been used in Mayo Clinic. The people might have seen the release of Google's MedPalm 2, and there's a little video if people are interested in watching it. And these generative AI programs from Google function so well that, in fact, it was actually acing its medical exam. So it is a very big area, and there's a paper for people that are interested in it. Along with the generative AI, there's also the predictive AI areas, which has been around, I think, longer, where big data is being analyzed for decision support systems. So, for example, the identification of cancer, where studies have found that with artificial intelligence programs, it reduces the miss rate of cancer by about half. But there are big challenges around these programs as well, as most of the training data sets are actually based on Western data sets rather than low and middle income and African data sets. Hospitals like the New Haven Hospital in Yale has actually developed a system of the Rothman Index. It's a tool that actually reflects patient acuity and risks and provide alerts. And this also have, some concern that there might be an exhaustion of over alerts, but in fact, this is a system that is implemented there. For us as well, what we are looking at is we're looking at some data analytics to look at the use of artificial intelligence to determine avoidable readmissions in emergency departments. And the little picture on the other side is just, we did a study looking just on Twitter perceptions of nurses during COVID and found that there was a strong axis between trust and nurses during COVID, although we couldn't isolate African data. The other thing that UWC is also doing is that we have in our faculty the new data analytics master's program that will be commencing. There's a big area on nursing informatics because the world is changing, and are we preparing people for it, and do our nurses and our other health information people have the competencies for it? So Prof. Bimaru from the School of Nursing is looking at information needs of primary healthcare nurses. Together with that, we're looking at the development of nursing informatics competencies. And what we have found, for example, is that nurses are quite comfortable with some of the computers, and because that's the way people are trained now with learning management systems, but that information management and information health informatics have got very, very low competencies, sort of at advanced beginner levels. We've also got some work with the Department of Health developing digital decision-making tools. We're working to develop a digital dashboard for CAMS mental health services. And then we've got a brand new student that's going to look at a very big project on digital health literacy for the workforce, because underlying all of these issues is that the workforce needs to be prepared. And then in public health, Dr. Verona Matthews has been ongoing work in this field as well. Telehealth is obviously, my PhD was in telepsychiatry, and so there's been we developed a framework, and the Department of Health is also now in the process of developing frameworks for telehealth and virtual consultations. And there's a project as well in the school looking at telerehabilitation for individuals with stroke. And of course, this field have changed from very formal, structured, big computer screens and systems to actually telehealth services on the phone. There's lots of educational issues in digital health, and I'm not even going to touch on them. And there's a number of students that we have that are working in this area. Then the other interesting field, which for me was as a start of this sort of project was really very interesting, is the number of digital education and digital other innovations that are happening. The field of virtual reality and augmented reality is just expanding rapidly. There's some work done in our faculty in sports science, and Prof. Titus, who was our teaching and learning specialist. We are currently working in a collaboration with the University of Missouri for the development of virtual reality scenarios for testing nurses' readiness to practice. And we're very excited about that project. We've got another collaboration with the University of Turku in Finland, where we are looking at smart gloves, and you can see an example at the bottom for CPR training. And we are actively looking to further collaborate with our new UWC Digital Innovation Hubs. There's also the area which is a very concern area, is this whole area of digital health technology evaluation. And we've got two current projects looking at this as well. We're looking at the development of a digital health technology assessment framework in collaboration with the University in Germany, Rwanda, and MUHAS. But also a separate project looking at the framework for evaluation of digital health interventions for women and children affected by poverty-related disease, with the University of Oslo are the main PI and numerous African participants in there. So what are some of the issues that are going to face us in digital healthcare and trying to ensure a sustainable society? I think that there's going to be this much stronger focus on this person-enabled healthcare, where people are looking at their healthcare issues on their phones. Predictive analytics, such as machine learning, will continue. A big challenge is interoperability, because with all these numerous systems that are on the go, are we able to talk to each other? And then there's the issues of governance, workforce, ethics, data governance, policy infrastructure. There's big ethical issues around safety, security, consent, distributive justice, and digital divides, and digital transformation of the workforce. There are challenges for consumers in the uptake of WOW due to language skills, lack of access, not being applicable to all services, fear and lack of trust of platforms, and in a lot of studies still a preference being expressed for face-to-face rather than for digital connection health service. The challenges for us, I think, is actually this gap between our academic preparation and what's happening out in the field, and the lack of opportunities for us to get experience in this. And I think there's a need for leadership, for digital proficiency, embracing innovations, and digital champions. And what we have to actually look at, I think, is look at what technology is in use so that we can prepare our staff. We have to do some work around health literacy, and we're planning to develop a health technology program. Working with the Department of Health on guidelines for virtual care. We're working with the University of Turku on a design course for health technology, and developing a digital education course. And then there's lots of research that is currently happening with a focus on partnerships, major collaborative transdisciplinary digital health case studies to be developed, digital health evaluation, and chatbots. And then to end off, I think there's tremendous potential in enabling universal access to healthcare, and to be an enabler of SDGs through the use of digital health technologies. But however, these digital health technologies should be located in an ethical framework. It should be based on needs and social justice, so to ensure that the equitable opportunity for everyone to access, use, and benefit from it. Thank you.
Thank you very much, Prof. Chips. What an insightful talk that you gave us. And I think it speaks a lot to what President Ramaphosa spoke about when he mentioned that the country is transitioning to a vision of having smart cities. And I think complement to smart cities would be having an effective digital system that is, very proactive and accessible to everyone, especially within the health industry. And I think given the opportunity, you could workshop us and give us more insight about different approaches to implement this more successfully. And I think with the research that you and your team are doing, it shows that there is room for it and there's pretty much plenty to learn from. Thank you so much for your presentation. Again, just to remind all the attendees that if you have any questions, you can just post them in the chats and our panelists will try to respond to your questions. And maybe at the end of the last speaker, we can open the floor maybe for 1 or 2 questions before we can close. So introducing now the last speaker, Professor Kista, who is a biotechnologist as a profession or in the Department of Biotechnology. He received his postdoctoral training in the field of plant molecular biology at GWC, Department of Biotechnology, where he was supported in his postdoc fellowship by the NRF of South Africa. He is a mentor in the Food System Research Network for Africa, the project which seeks to strengthen food system research into implementable policy solutions and practical interventions in support of sustainable goal development and the targets for Africa. He will be speaking to us about the use of biotechnology and its tools to study the plant-to-human health nexus, the plant-human nexus health. Over to you, Prof. Marshall.
Thank you, Dr. Malema. Can you hear me?
Yes, you are audible. You can share your screen.
Can you see my screen?
Yes, whenever you're ready.
Okay. Thank you to the Office of the DVC for this invitation. Today I'll be talking about what we have been doing in biotechnology to advance SDG3, which is human well-being and human health. So just to start, since I'm the chair of the Department of Biotechnology, I must start with a definition. So biotechnology is a very broad field, and it covers many aspects of the sciences, but mostly we try to use living organisms, and we use those living organisms to make novel technologies and processes to advance sciences and everyday life. So these are just showing some of the fields or some of the areas that a biotechnologist will study. So you have the pharmaceutical technologies, and there we work very closely. We work very closely with our colleagues in pharmacy. We have the enterprises. These are the people that are now moving some of our products into the market. We have biodefense. That is also a very interesting field, and that is where people are working on biological warfare. And then in our department, we have a big area on molecular biotechnology, where we use DNA, RNA, and protein to advance certain aspects of the sciences. So the plant-human health nexus So this is a very interesting area of the sciences, because we often think that we can do plant science without engaging with the people over in the human sciences, and vice versa. And so our group are now focusing on how can we bridge that divide, and how can we use our knowledge of the plant sciences to advance the area of human health. And so my colleagues came up with a theme, and they are calling it the One Health umbrella. And this is out there, but I'm rephrasing it to the plant human health nexus, because that explains mostly what we are trying to do. So we are trying to use plants or plant-derived products to then use those products to use them in processes to where there's diseases in humans. But we also have to focus on the plants as well. And so this paper mostly summarized what we are trying to do in a very complete diagram. So we are using the plants. We use genomic information, so we are sequencing plants. We are sequencing bacteria, also in fungi. We have just published a paper on microRNAs, where we use the microRNAs to see if we can dock that to some of the diseases in some of the cancer diseases. We have used protein peptides also to see if we can study viruses, both for detection of the viruses, COVID-19, as well as therapeutics. We're using proteins as well as some of the chemicals that we get from screening plants. And then recently we published a paper in Nature Reviews Microbiology, where we are trying to advocate for studying the human microbiome. So this is mostly focusing on a gut microbiome. So this picture says it all. Basically, from food, and something interesting which I picked up from the chat was when Rina said that legumes is under-consumed, and so that is a big worry. And just to add on to what Rina was saying, I think it is it's culturable. So culture. So different cultures will eat different aspects of the foods, and so some of the legumes are mostly consumed in a certain culture, certain population. And so if we can maybe expand that and get the message across that these legumes have high vitamins and nutrients, and across the whole population, then we can really make a big difference in human nutrition. So my lab focuses on common bean, and we are mostly studying the green bean variety. And these green bean varieties have been used in many of our dishes. In most of the cases, people look or feel healthy when they eat a meal. But the plants also depend on the healthy individual. So when people feel down, they're not going to have the energy to go and look after the plants and feed the plants and provide fertilizer for the plants. So and then that will enable these plants to grow again. So this is a cycle that is very interesting, and this actually summarizes the plant-human health nexus. And so in this talk, I'll be focusing mostly on the work that we've been doing on fungi. So this is a microorganism that we know causes disease, but there's also benefits to these fungi, and I'll touch on the benefits in my talk. So the first part is to focus on how do we use the fungi to make our plants healthy. So in a study with my colleagues from CBUT, we studied an endophytic fungi, which means this is a fungi coming from internal plant tissues. And I'm just going to call it B. bassania. So this fungi was mainly used to control insects. So this is also in farming systems. And so they saw that this fungi is very good in controlling these insects. And so my colleagues wanted to know, is there other benefits from this fungus? And they started to grow so tomato, and they saw that tomato grows much better just by applying B. bassiana to the tomatoes. But then they also know that there's other fungal species like Fusarium oxysporum that that infects tomato and then causes yield losses. So this image was basically done by my PhD student Gerard Basson, and he had to do this because we were going back and forth with one of the reviewers, and so we had to basically prove that this species of Fusarium oxysporum was a Lycopersicki, which is the forma specialis for tomato. So, which means that this Fusarium oxysporum infects tomato. So we went through all of this and we did all of the molecular sequencing, and we showed that this is a Fusarium oxysporum, Lycopersicki. So when we did the treatments, T1 is the control treatments, T2 is the infection. We can clearly see there's a difference in the growth, and there's definitely disease in these plants. And when we add bassiana, they look much bigger than the control. But then when we do the combination treatment, we found that bassiana actually controls the Fusarium oxysporum, and we get much better growth. And we still have to grow these plants until they fruit. So this is just a table from the paper showing that we showed improved plant height as well as the number of leaves. And so this was very, very important work, because when a fungal species like Fusarium oxysporum, like Lycopersicki, goes through a population of tomato, and if there's no resistance, they can wipe out that whole population, and we can lose so much in terms of output of tomatoes. So in the next study, we then move through what I do at UWC. So I look also into heavy metal stress on plants for two reasons. So plants are sensitive to these metals, but also we as humans are sensitive, and these metals causes they are toxic to us, and they have human health negatives. So we isolated a whole range of fungi from a weed called buckwheat, and so this weed grew very close to mining sites. And so my collaborator from Stellenbosch, he used the fungal endophytes to control Mycobacterium tuberculosis. So this is the bacterium that causes TB. And he found that this one, which we coded C. liu, this one had interesting properties that inhibit the growth of Mycobacterium tuberculosis. And so he was very interested to see, is there other benefits to this whole panel? And we found that when we added in a combination treatment vanadium and these fungi, we saw effects on whole plant height. And we were very interested in C. liu, not because only it inhibits Mycobacterium, but also because we saw that it rescues other plants under vanadium stress. So when we looked at pot number, because pot number is very important in the common beans, because this is actually the part that we consume, we saw that the C. liu one actually had the highest pot number, and this is under vanadium. And so my student, Sadrina, she completed her MSc, and she is now going to graduate now in September. So there's also this new thing that is now in the market, where people are doing extracts from chlorophyll. and they're using this for benefits, for human health benefits. And some of the benefits are skin, at the skin. They promote weight management, promote weight loss, increase in natural energy. And so we have all of these plants, and we just discard them. But we don't know that we are actually sitting on a gold mine, because if we can extract this chlorophyll, we can then take it to market. So what if we? So this is the reason why we looked at also at chlorophyll as a response under vanadium, because we know when you treat plants with vanadium, there's a decrease in chlorophyll content, because as in this result here. But when we added the CLU in this one here, we saw that when we have CLU in the treatment, we increased the chlorophyll, the total chlorophyll content. This has benefits to the plant in terms of photosynthesis, but also for us, because if we can now use that chlorophyll, we can get, this is a good source also of magnesium, because in the center of the chlorophyll there's magnesium. So then we had to look at vanadium concentration. So we looked at roots versus leaves to see how our fungi affects the transport of vanadium, because if the vanadium is transported into the leaves and into the pods, then that is not good for us, because we consume the plants. So we saw that CLU under the treatment basically keeps the vanadium in the roots and translocate a low amount of that vanadium into the shoots, which is a good thing. So that concluded our study on vanadium and fungi. So this is done now with the plants and the fungi. We have all of the other work going on. We are also looking into bacteria and how bacteria plays a role in improving plant health. So now I'm going to move over to what we are doing today, and that is SDG3. So we have written a review where we looked at fungal compounds, because we are interested in the fungi. And so we looked at fungi. We came up with 82 fungal derived compounds, and some of the compounds we then used in docking studies to see how they dock certain important proteins in Mycobacterium tuberculosis. And we found that these fungi, there's a whole lot of bioactive compounds which can be used as TB drugs in the future. And so we then had to now go and find interesting regions, interesting organisms to go and get the fungi from. So we started off by going at to marine environments, because other groups also at UWC in pharmacy, in chemistry, they have looked into this, and they found very interesting results from the marine bacteria. So we are looking into marine fungi. We published that paper in Lilium recently. So we extracted 10 fungi. We then saw that MGK33 for the short code. When we did a fungal extract, just a normal extract, and we then used that extract against Mycobacterium smegmatis, which is the non-infectious mycobacterium that everybody uses in the lab. And we used that against Mycobacterium smegmatis as well as Mycobacterium tuberculosis. We saw that there was an inhibition at a very low amount. So the MIC is the minimum inhibitory concentration. And so we were very interested in this fungi, in MGK33. So we got it from the European Sea School. We then used bioinformatics to now dock some of the chemicals that we got from a LCMS screen from the fungal extract, and we came up with bionectin F, and this was docked against a protein that's very important in Mycobacterium fatty acid synthesis, which is a beta keto HL reductase. And when we docked that, we saw that bionectin's got a high binding affinity to this protein. And so in that conclusion, we found that bionectin could be an important inhibitor of this protein, and we can then go forward to see if we can use that as a treatment against TB. So what we did was, in short, we then try to now use this extract to see if we can incorporate into nanoparticles, because nanoparticles will then further reduce the amount that we need from the extract. And we saw that when we use magnetic iron oxide nanoparticles just on its own, the viability of smegmatis was the same as the untreated cells. But when we added MGK33 to the nanoparticles, we could reduce the cell viability of Mycobacterium smegmatis. This work needs to now be translated into Mycobacterium tuberculosis, but we are very, very hopeful. So, and against cancer, we got fungi from a wheat, which everybody have probably seen on the roads. This is hairy fleabane that's growing all over the Cape Town region. So we found 5 fungi. We then ID'd the fungi, and then we saw that one of the fungi, DR13, has these fungal compounds inside just from a screen. So now we don't know whether this will have anti-cancer properties. This is just identified. So we took the extract into an assay where, if you use resazurin, which is blue, and this resazurin, you add it to a cancer, which is a viable cell, it will be converted into resorufin, which is pink. So more viable, more pink. Less viable, more blue. So we used a breast cancer cell line, which is used all over in laboratories, and we then now added the extracts onto there to see, do we have anti-cancer properties? We then found that some of the fungi makes the cancer more aggressive and makes them more growing more faster, like DR1 and DR7. But we saw that DR3, DR4, and DR13, there's some inhibition. DR13, there's no growth of the cancer. So now we are sitting with this fungi. We have the compounds. We now need to see what are the compounds responsible for this result. And I want to thank all the collaborators, my collaborators from Missouri University, the ones from CBUT, from Stellenbosch University, as well as the University of Free State, and then my students who conducted the work in the laboratory. And I thank you for listening.
Thank you so much, Dr. Prof. Marshall, for your very insightful and fantastic work that you're doing in your department and with your colleagues, both from locally and internationally. And also let me extend my appreciation to all the panelists and all the attendees that has stuck out and listened to all the presenters. So what we're going to do now is that we're going to open a floor for some Q&As. I think there's been some questions that has already been answered in the chats. So for the next 9 minutes or so, maybe we'll just ask each panelist to give a response statement. Then I think if each can get an opportunity to respond, then I think that would be highly appreciated. And then the panelists, if there's any questions, you can either raise your hand or post your question in the chat, and then if time allows, we'll see how many we can address. If not, we can always use emails and other platforms to communicate. So maybe just to get started, and I think all the panelists can respond to this. If everyone can put their cameras back on. Thank you. I think you've shared with us your wonderful work that you're doing. So maybe as a statement or other question from my side is that seemingly we are almost at the end of the Agenda 2030 of the SDG goals. And, you know, there's been so much that has been done in different pillars of the SDG. So as an institutions, specifically at UWC and your partnering institutions and the research area that you're in, do you think we are on the right track, and are we contributing enough towards the SDG goals? There's no, whoever feels like answering, they can respond.
I will venture an answer, and I think this is very discipline specific, and the answer will probably differ depending on that. I think we can do much more. I would really like to see a health promoting campus. We already made great strides on, for example, environmental friendly plants, you know, planting only indigenous and that kind of strategy. For me, having a healthy food environment and a healthy campus or health promoting campus for me is equal to that kind of decision. Somebody just needs to decide it, and it needs to come down, and everybody, you know, we need to go work towards achieving that. My 2 cents on that question.
Thanks, Prof. Prof. Chips, your take?
You know, I think there was a very interesting question that was asked about, you know, the issue of the digital divide. So I think for us, I think the challenge for us is that I think there's tremendous potential and opportunity, but there's a major challenge ahead, and I think we can do much more around improving equitable access. I think that is a big challenge that remains for us in terms of digital health literacy, infrastructure. You know, you just have to look at, for example, that, you know, in some of the projects we can only provide SMS messages as opposed to, you know, apps that due to connectivity and etc. So I think there's a lot of work to be done, and I think for me, I actually think that one of the things we at UWC should do is that we have to improve the digital health literacy of our health workforce. I think our health workforce is not prepared for what is currently happening around us, and so I think that should be one of our small little challenges, but they're big challenges as well. Thank you.
Thanks. Prof. Marshall, your reaction?
Yeah, I have to agree with the 2 colleagues and what Rina said about promoting on our campus. We have the Center of Excellence part on campus, and we are talking about providing food to our students, yet we bring in a vending machine. So I'm just saying, it's not that I'm looking down at these things, but we have been talking about how to grow plants and how to then feed our student population. When we talked about this, we said we have rooftops which we can use. We have spaces available for hydroponics, but we have to, like Rina said, we have to start somewhere, and all of us have to get our hands dirty and then go forward with something like that.
Thank you. And lastly, Dr. Nyamezi.
Yeah, thank you so much. There was a question from Tamzon, which was basically trying to say that we are not doing enough for the mental health, and I think I agree with her, because what we're not doing much is to say, like, as a university in our population, we do have all these health well-being day and the likes, but I think what we're not doing, we're not giving enough attention to mental health, both for staff members and for our students. So we need more programs that will be looking into the mental health of our community, and we can start doing that by streaming and looking at all the issues that affects them in their life and at work as well.
I saw there's a comment from Paul. I'm not sure if the colleagues would mind sharing their presentations, Dr. Mdeleni. I'm not sure if maybe there's a platform to make the presentations accessible, but then I think if there is such, maybe your office can give direction about where can our attendees reach out to this lovely work that is being done in our research. Maybe you can shed some light on that and you can give us the closing remarks.
Thank you, Dr. Malema. Firstly, let me just extend my gratitude to you for a session well run. We're truly appreciative. With the presentations, they can just source them. They must email the DVC email account, dvcrni@uwc.ac.za, and request the presentations, and then we'll finish them with the presentations. Also, I want to extend a word of gratitude and my utmost appreciation to our panelists. We value your time, we value your effort, and the insights that you've shared today are invaluable. And we say that we need to stop operating in silos. We need to start adopting a collaborative approach, a shared approach, because one can tell that there's a shared agenda in the presentations that were presented today. And therefore, how do we then develop a working relation and move from our caves of excellence and hold hands in terms of our approach in contributing towards sustainable development. So this is a challenge that I'm extending to our panelists. I would like to see this extended beyond. I'm happy to bring everyone in under one roof, perhaps through your students, perhaps through your research partners, and see how do we then develop from here? How do we progress from here? Because it's nice to have webinars, but we don't want to do lip service. We want to get our hands dirty. We want to make sure that our talk also has a meaningful impact. So our support from the Office of the DVC is there. As I say that we are the Directorate of Research. We drive this. We're passionate about this, and we understand its importance, in particular to the UWC populace and the communities that we belong to. So having said that, once again, on behalf of the DVC, she did join momentarily, and she had to be excused again. We really appreciate your effort, and thank you so much for your time. To our audience, thank you for joining us today. We understand your challenges with power, but we had over 50 people throughout the webinar. So thank you so much. Over to you, Dr. Malema.
Just to echo your appreciation to the audience, I think we've had a very handsome attendance today, and I think from the panelists themselves, you've really shared some valuable research, and I think going forward, maybe we might have an opportunity together in one space and be given sufficient time. I know the 20 minutes sometimes it's very limiting, and there's so much to just to speak. Maybe I think just as a challenge on my side to the DVC and to the research office, so Prof. Phillips in attendance, try to organize a day workshop and invite our fellow colleagues to come and workshop us on the wonderful research that you guys are doing. But with that being said, I think it's now peak hour for those that will be driving. All the best, drive safe, and hopefully we'll see you again in the next webinar. Thank you so much.
Thank you.
Thank you.